Hey there guys, how you doing? And now we're looking at parathyroid hormone and thiazides. Okay, I thought of making them a different topic, but separate topics. But since they're quite small topics, it didn't make sense to make a separate video on both of them, since both of them are acting on DCT, that's the distal convoluted tubule, and both of them are interlinked in some way. So first we'll be looking at parathyroid hormone. Parathyroid hormone also acts on the DCT like thiazides. Now, before that, we have to remember one small detail, that's DCT is responsible for reabsorption of sodium chloride and calcium ions, and sodium chloride 5 to 8% reabsorption takes place. Okay, 5 to 8% reabsorption of sodium chloride takes place in the DCT. So one point to remember. And calcium ions also reabsorbed with the help of parathyroid hormone. Now parathyroid hormone, so blood, urine is containing sodium ions as well as calcium ions. Parathyroid acting here. Because of this, calcium channels open up and calcium is reabsorbed. Now parathyroid hormone aims at what? It aims at increasing the blood calcium levels. Okay, so it's going to increase the dietary intake of calcium. It's going to reabsorb calcium from the bones. So, and it's going to also take calcium up from the urine. It's going to reabsorb calcium from the urine, aiming at one particular thing, and that is increasing the blood calcium levels. Now, to move calcium from the urine, first it has to move the calcium into the cell. Next, it has to move the calcium to the blood. Now, calcium is exchanged into blood by two mechanisms. One mechanism is with expense of ATP, that is, the calcium ions are exchanged for hydrogen ions with the expense of ATP. Then, it is also seen that the calcium ions can also be exchanged for sodium ions without the expenditure of ATP. So calcium exchanged for sodium without the expenditure of ATP. So parathormone acting on the cell causes calcium to get into the cell, and then calcium is brought into the bloodstream by two mechanisms: exchange with sodium and exchange with hydrogen ion. Now, the agonists and antagonists of parathormone will be dealt separately when we're talking about the endocrine system. So this much is all you need to know, because most of the time parathyroid is not actually used in any of the renal disorders nor the heart disorders as far as practical applications go, because we have particular better drugs in controlling the situation. But in endocrine disorders, yes, parathormone does come into play. So we'll be discussing it separately when we look at the endocrine system. Continuing further, we'll look at thiazide diuretics. Now, thiazide diuretics are having a thiazide ring, hence the name thiazide diuretics. Now, thiazide diuretics are medium efficacy because they're only acting on the 5 to 8% of sodium chloride which is being reabsorbed. So, these medium efficacy drugs, since they are going to be acting on the sodium chloride symport channel or the NCC, this is the name of the symport through which they're passing. The drugs which are acting on this, though in broad term are called thiazide diuretics, they are the ones with the thiazide ring, and which do not have the thiazide ring but still they act like thiazide diuretics, so hence they're called thiazide like diuretics. Now, classification, this is the classification. The names can be remembered with simple mnemonics. So with ring, HB, okay, that's 2HB, and thiazide like can be CC mix. So the mnemonic for both of them have been put up. So now we'll just come to the drug names. With ring, so actual thiazide diuretics, HB, the H, hydrochlorothiazide. That's the first one. The thiazide is the common suffix for all the drugs from here on out. So I'll just omit that. Benzthiazide, hydroflume thiazide, and bendoflume thiazide. So 2 flumes and 2 hydro. So it's easy to remember. It's not that difficult. Now coming to thiazide like diuretics, C mix. Chlorthalidone. Okay. The suffix, which is pamide, is only shared by 3 drugs. So clopamide, indapamide, and zipamide. Wait, I'll check my notes. Yeah, zipamide. So zipamide. The suffix which is commonly shared here in case of these 3 drugs, pamide, pamide, and pamide. Okay. These 3 are sulfonamide derivatives. As we saw in case of carbonic anhydrase inhibitors and as we saw in case of loop diuretics, they are also sulfonamide derivatives and hence are responsible for cross allergy in certain cases. So these 3 are sharing the amide suffix, the others are not. So chlorthalidone and metolazone. Okay, so these are the drug classifications. The mechanism of action is by blocking the sodium chloride symport. Okay, the cell of DCT, blood, and urine. The sodium is taken in along with the chloride ion, and this sodium is exchanged out to with the ATPase enzyme with potassium. So that's how much we guessed. And then this mechanism is going to be blocked by the drugs. Those are the thiazide group of drugs, and hence sodium is going to pass on and lead to increased amount of volume of urine being lost, because that volume is going to be responsible for the dilution. Now the ions which are going to be lost are not just sodium or chloride, because as I discussed in the earlier video, sodium, when it travels to the collecting duct, okay, or the cortical collecting duct as its full name is, it's going to be exchanged for K plus under the effect of aldosterone, leading to potassium wasting as well. So we add that to the group. So sodium, chloride, and potassium. Also calcium. Now how calcium? If you look back at the parathyroid mechanism, yeah, let me just pull that up. The parathyroid mechanism stated that for parathyroids to work, okay, they are going to need calcium to be exchanged for sodium. So sodium should be present in your blood for calcium to get out after exchanging itself for sodium. So what would be happening in case sodium is not available in the blood? So sodium here was exchanged for calcium, and so in case sodium is not available, there is not going to be any reabsorption of calcium. Okay, so since calcium is not being absorbed because there is no sodium present to exchange with it, you're also going to be losing calcium as well. So ions which we are lost are potassium, chloride, sodium, and calcium as well. So these are the ions which are going to be lost in case you're using thiazide diuretics, and to dilute them you're going to have an increased loss of water. So if you look at the classification of drugs based on efficacy, okay, highest would be loop diuretics because they had a lot of ions going for them. They had sodium, they had potassium, they had calcium, they had magnesium, they had chloride. Next would be thiazide diuretics, which act on all of them except magnesium. So sodium, calcium, chloride, and potassium. Then low efficacy drugs being carbonic anhydrase inhibitors, which act basically on the bicarbonate ions and sodium ions to a certain extent. And even lower we have osmotic diuretics, which will be taken up later on. Osmotic diuretics which include mannitol, and glycerin and isosorbide. Okay, so this is depending upon the efficacy. Now we'll come to their clinical uses. Clinical uses of thiazide diuretics is in mainly hypertension treatment. Okay, because of their medium efficacy, they cannot be used in very hypertensive crisis, but they can still be in prophylactic maintenance of hypertension or control of hypertension, because they have longer duration of action than loop diuretics. Loops were having around 4 hours, they have from 8 to 12 hours of action range, and hence 1 tablet a day or 2 tablets a day are sufficient to maintain the hypertension in the given patient. But they're not given alone, they have to be either given with potassium pills, potassium supplements, or they have to be given with potassium sparing diuretics to compensate for the potassium loss. Now, other than hypertension, since they're reducing blood volume, they can be used for chronic edematous states like edema as a side effect of other drugs, ascites, etc. Even pulmonary edema to a certain extent. And they can be used in case of congestive cardiac failure to reduce the blood volume and to reduce preload. Yeah. So these are the uses. There one more particular use about this, since actually not the use, the adverse effect is calcium stones. Okay, since increased concentration of calcium is going to be occurring in urine because of reabsorption, they might lead to calcium stones. So that would be a use of parathyroid hormone, because parathyroid hormone prevent calcium stone formation. I think I forgot to mention this in the first part of this video, so I think you should make a note of it. Parathyroid hormone, since it's decreasing the calcium concentration in urine, it's going to reduce the incidence of calcium stone formation in the kidney. So we completed all the topics. So the main topic which is left would be adverse effects. So adverse effects, as I earlier said, hypokalemia, hypocalcemia, hyponatremia, and you're going to see hyperuricemia, hyperglycemia, and hyperlipidemia. I think we saw all hyperlipidemia and hyperglycemia and loop diuretics as well. Yeah. So one more thing to add up, and in case you're using thiazide like diuretics, you might be faced with sulfonamide allergy as all the other classes. And same thing as we said about NSAIDs in the previous videos, NSAIDs lead to decrease in efficacy of thiazide diuretics. So if you want the mechanism, you can go back and refer into loop diuretics video. So I think I've covered almost all of it. One more thing, if extra note, if you actually wanted to know the case. So imagine a patient comes to you who's suffering from hypertension as well as diabetes mellitus. Now, hypertension can be treated by diuretics, and they can be treated by beta blockers as well. And then there are other drugs like angiotensin receptor blockers, ACE inhibitors. Okay, so if a person is having both hypertension and diabetes mellitus, you should be considering diabetes mellitus, and you should avoid giving the person diuretics and beta blockers, because beta blockers mask the hypoglycemia which the person will be suffering, and hypoglycemia can lead to severe complications. Yeah. Now diuretics, as we are not using acetazolamide as antihypertensive because of its very low efficacy, we are left to use either loop diuretics or thiazide like diuretics. Now, or thiazide diuretics, yeah. So these two things, loop diuretics and thiazide diuretics, can cause hyperglycemia and hence are contraindicated in case of diabetes mellitus, because that person is already suffering from hyperglycemia. Yeah. So beta blockers and diuretics are cancelled. So it's better to treat them with angiotensin receptor blockers, AC inhibitors, or direct renin blockers. Okay, but direct renin blockers, as they are expensive, it's better to stick with these two. So you can treat them with captopril, enalapril, or losartan and valsartan and all those. Yeah, so this is a side note. So anyway guys, thank you for watching. I'll catch you back up in the next video where I'll be discussing osmotic diuretics, and we'll see about potassium sparing diuretics, ADH antagonists and agonists and all those things. Yeah, thank you for watching. Bye.